Welcome to the Virginia Hospital and Healthcare Association's Patients Come First podcast series. Episodes are available on VHHA.com and on popular podcast hosting apps, including Apple Podcast, Amazon, Spotify, and many others. We're a member of the Public Health Podcast Network, the Virginia Audio Collective, and the World Podcast Network. Episodes also air Sundays at noon on 100.5 FM, 92.7 FM, and 820 AM across Central Virginia, 1650 AM in Hampton Roads, 105.1 FM, and 1050 AM in Lynchburg, and Wednesdays at 1 p.m. on 93.9 FM in Richmond. Please send any questions, comments, feedback, or guest suggestions to pcfpodcast@vhha.com. Again, that's pcfpodcast@vhha.com. Today we're thrilled to be joined by Dr. Mateo Ziu, a neurosurgeon from Inova, who joins us to talk about his medical journey, an innovative new procedure to treat patients with brain tumors, and more. With that, welcome to the show, Dr. Ziu. Thanks for joining us.
Oh, thank you very much for the invitation. It's great to be here with you.
Yeah, we appreciate you taking some time. Return listeners of the show will know that we generally start these conversations just by trying to get to know our guests a little bit more. So, did a little bit of research on you. We know that you began your medical education in Italy before a research fellowship at the Harvard-affiliated Brigham and Women's Hospital, an internship at the Vanderbilt University School of Medicine, neurosurgery residency training at the University of Texas Health Center at San Antonio, I believe, and then as a clinical fellow in neurosurgery oncology at the University of Texas Anderson Cancer Center. I believe you also earned an MBA along the way, so a lot of impressive and hard-earned credentials. But beyond those achievements, tell us what folks should know about you and your own personal story.
Yeah, no, thank you very much. Yeah, that is I'm very proud to. I'm from Albania, where I grew up, and I had the opportunity to go to Italy to do my medical school. Certainly, there are certain circumstances that kind of drove me to go there, but I was very happy to do that medical school there and learned a lot. And after that, I migrated here in the United States, where I did, as you mentioned, research. And I started on the laboratory at Brigham and Women's Hospital with Dr. Peter Black and Rona Carroll there. Worked with them in brain tumor research. At that time, certain angiogenesis and certain factors was new, and I researched there, and then I did the surgical internship, and then neurosurgery training and a fellowship in neurosurgical oncology at MD Anderson Cancer Center in Houston. So after that, I worked in Austin when the Dell Medical School started building the brain and spine tumor program there, but then the Inova Neurosurgery recruited me when the Shar Cancer Institute started to build a program together with the team and a team here at Inova. So that's what I have been here for approximately almost 7 years now, building this program. I'm the director of the brain and spine tumor program at Inova. We have a great team of neurosurgeons, well-trained. Personally, I'm a fellowship trained as a specialty trained in neurosurgical oncology. We have other neurosurgeons as well that work in the brain tumor patient and spine tumor patients. And as well, we have a great team of radiation oncologists and neuro-oncologist, Dr. Adam Cohen. That is kind of for the physician teams.
Awesome. Thanks so much for sharing all that background. I appreciate it. This is sort of I'm going to dumb the conversation down just a little bit for my own curiosity. From the beginning of your medical education to the time you finished, I mean, I'm sure you're a lifelong learner and all that sort of stuff, but from the time you began medical school to the end of your residency and fellowship, how long did that whole process take you? I'm always curious to know.
Well, I think it's so doing the medical school in Europe is a little bit different than here. In Italy, the medical school is after high school. We go to the med school in most of the countries in Europe, and the medical school is 6 years. Then I did 2 years of fellowship research. That was research education, and then it's an internship and neurosurgery residency, and that is the neurosurgery residency is 7 years.
Okay.
And plus 1 year of clinical fellowship, further training in neurosurgery for treatment of tumors only, brain, spine tumors, and pituitary tumors, yeah.
Okay.
So what was that, 7, 8, and
1?
6, probably 14 one
Yeah.
kind of for almost 20 years, yes.
Well, that's a long time. That's impressive and reassuring. Fantastic. I mean, wow, what a journey. Well, I want to take you back to sort of the beginning of that journey. What was the inspiration for you to pursue medicine? And then once you got into it, what was the inspiration for you to pursue the neurosurgery specialty?
Yes, it's a little bit, kind of has been so many years, but I remember kind of in that time in Albania when I was finishing my high school, a little bit through the books, but as well during my time that when I was finishing my high school, I volunteered with the Missionaries of Charity, Mother Teresa, kind of the mission of the Mother Teresa. And that's what I kind of saw for firsthand, how, the treatment of how they helped the missionaries and the Mother Teresa were helping the poor, but as well as the sick. And that's what kind of inspired me to go to medicine, to pursue that career. Yeah.
That's very cool. Well, I want to shift gears a little bit and talk more specifically about your specialty. And I'm eager to learn more. As we mentioned before we hit record, I did a little bit of reading just to try to prepare myself for this conversation, but I know that
absolutely.
I'm going to learn a lot more from you, so this is really exciting. I want to share a little bit of sort of 30,000-foot view information for the listener, and then hopefully you can fill in the gaps a little bit. So,
yes.
In generally speaking, brain tumors can be caused by different cell types and can present in various symptoms. Data indicates that approximately 90,000 brain tumors are diagnosed in the U.S. each year, with about 28% of those being malignant. Treatment for brain tumors can include radiation therapy, surgery, depending on the situation. So with that sort of brief general introduction, what else can you tell the listeners about brain tumors and the treatment for them and the outlook and all that sort of stuff that you've seen over the course of your career?
Yes. So there are different type of brain tumors, almost, we can say at least 120 type of brain tumors, but to be more kind of, and not to go on all tales, we define them as benign and malignant. That is one of the first division that we do. And when we define benign and malignant in brain tumors, it's a little bit different from the tumors that come in lung, breast, and other organs. That generally when they are malignant means that they are going in other organs, spreading out. In the brain, most of these tumors, kind of we define it benign and malignant, how fast they grow. And certainly that is one of the definition. The tumors that grows very fast, most likely is malignant. The tumors that grow very slow are benign. However, in the brain, you have to understand kind of it's a very small space that is occupied by the brain. So when you put a tumor like this that is occupying space as well, it will create a lot of symptoms in the brain. So benign or malignant means not a lot in the terms of, really the nomenclature, the name. The most important thing is that what kind of symptoms they are causing when they grow. However, the malignant tumors certainly are a different category, but even the benign one we have to consider them very carefully, the treatment that we do, and they need to be treated, many of them. The other classification of division that we make is a primary brain tumor or secondary brain tumor. We have to kind of remember that the majority of tumors that we find in the brain are tumors that come or travel from other organs. Nowadays, we have so many treatments, and the oncologists have done such a great job of kind of treating breast cancer, lung cancer, colon cancer, etc. However, as the time goes by and the patients survive longer, unfortunately, some of those cells will travel to the brain and they'll create tumors there. And the problem with that the brain is very isolated, or it is an isolated organ. And some of the chemotherapeutic that we have don't penetrate the brain, so don't reach these tumors. So that's why we have to kind of the treatment of brain tumors is a very what we call a multidisciplinary approach. It's not only one specialty or only one person. It's something that needs to be treated by different specialty physicians, medical oncologists, neuro-oncologists, neurosurgeon oncologists, radiation oncologists. So it's a team that has to treat them. So this is kind of a big view of these tumors. Some of these tumors can be treated, depending on the type, can be treated just by surgery. some of these tumors need surgery and radiation, or surgery and medical therapy, chemotherapy, or now we have newer medications, newer type of treatments, and or some just need a biopsy from the surgeon to know what it is, and then they can be treated just by radiation or chemotherapy. So they are different. It's so variable, so different for all the type of tumors.
Yeah, absolutely. That makes a ton of sense, and I appreciate that background information. I want to kind of zero in on something that you touched on just a moment ago when you talk about some of the new innovative treatments, and you outline some of the more, maybe it's not fair to say traditional treatments. They're all cutting edge and brilliant in their own way. But the thing that I want to dive into a little bit is this new innovative procedure called gamma tile therapy. And Inova recently became the first health system in the Mid-Atlantic region to offer this procedure. As a layperson, the way I understand it is the goal is to prevent the recurrence of brain tumors after radiation and surgery. And to accomplish that, the procedure involves placing these sort of biodegradable tiles. Maybe that's not the right term, but these tiles in the brain that use radiation to target tumor cells and then prevent them from recurring or from growing back. What am I missing there? Fill in the gaps for us a little bit on that particular therapy.
So kind of getting a little bit back in the sense, we have so many type of radiation, and Inova has been kind of in the forefront of having all the available technology for our patient, putting the patients first. There are type of radiation, like we call conventional radiation. Then is the more precise radiation, is the cyber knife radiation, or some people in other institutions have a gamma knife, but this is a cyber knife we have. It's a proton beam radiation. So there are so many type of radiation that over the years, radiation oncologists, and believe it or not, neurosurgeons together, radiation oncologists have come up with these new type of technologies, etc., to treat these tumors. So before I go to the gamma tile, I wanted to talk a little bit about what's the reason, after you have removed surgically a tumor, what is the reason behind certain treatments. So as you can imagine, when you treat a tumor in some other organs, like say a skin or a lung or a breast, many of the surgeons do these resections that remove as well what is thought to be normal tissue, because we are concerned that the tumor has infiltrated even normal tissue, even though the imaging, the MRI, CT, or whatever doesn't show the tumor. So while you can do that in certain organs in the brain, you cannot really go beyond the certain limits because the functionality of the brain. So that's why after we remove the tumor, we stay within the margin of the tumor. It's very hard for us to pursue what we call remove the tumor outside the margin, because we have to preserve the function. That is the most important thing. We have so many neurosurgical techniques. That's why the fellowship trained us as well, how to preserve normal brain and remove the tumor. So now what happens is that as you remove the entire tumor, there are cells that still we cannot see with our eyes that remains in the area of what we call surgical cavity. And so then we have to treat these cells that remain beyond the surgical cavity or the surgically removed tumor that need to be treated. Otherwise, the tumor will recur, will come back. So that's why we have so many new techniques. The gamma tile per se is another technique of radiation therapy, but it's kind of what we call local, or is where we put the radiation in. Every other radiation is outside, where everything is closed. It's like pardon my kind of comparison. It's like putting something in a microwave. Mm-hmm. So where the radiation comes from outside although it's specific, is directed to the specific area that you need to treat. Instead, these gamma tiles put the radiation inside the tissue and radiate it from close in. So I hope I'm kind of not being too technical with the terminology.
No, that's fantastic. That's really interesting.
So this technique, kind of before where we put these radiation beads is a cesium. That's a radiation bead that they are very, very small, very, very thin. that you need to put them, of course, in the brain or any tissue. They will move all around. They'll go because, of course, there will be fluids and blood that may go around. So the gamma tile was a product that came very kind of recently it was invented by a radiation oncologist surgeon down at, I believe it's the Barrow Institute, Neurological Institute in Arizona. And so what they take, they are kind of 1 inch by 1 inch, very thin collagen material that over time, as you said, is biodegradable, get absorbed. And inside of the very precise kind of distance from each other, they put these beads of radiation. So after we have removed the tumor, we put these, they call them tiles because they are thin like tiles, but they're collagen with these cesium. We put them in a surgical cavity, like imagine a hole, that you have opened
Sure.
somewhere, and then you put just in the cavity, and they stick there and they stay there. So as we have closed the skin, closed the skull and everything, then these radiation beads can start continue to radiate for approximately 10 to 15 days. And a little bit kind of is a half-life and a little bit longer, but mostly that's the kind of half-life. And they continue to radiate and destroy the cells that probably were left behind as we removed the tumor, and we didn't go beyond to protect the functionality of the rest of the brain. So I wanted to mention that bringing these new technologies, a new type of treatment, innovative treatment to our patient, especially the gamma tile, it has to be needs a great collaboration between all the specialty physicians for treatment of brain and spine tumors, neurosurgery, neuro-oncologists, radiation oncologists, and all how the decisions are made. However, these will not be possible without the help of the Innova administration that is behind us, helping us assist our patients, putting our patients first.
I have a million different questions about that process. It's so fascinating to me. The direction I want to take it, though, is this. So obviously it's an innovative procedure. It's new for Innova. It's new in the Mid-Atlantic region, as we mentioned. But I wonder if you can talk about some of the outcomes that have been seen as a result of this new procedure, this new technique. How has it improved patient outcomes, or what's been different since this has come into play?
Yes. Yeah. So as we mentioned before, once a patient is diagnosed with a brain tumor, and certainly we didn't talk, but the brain tumor can be diagnosed, can be found in many different type of symptoms: headache, a seizure, neurologic deficit, meaning feeling weak on one side or the other, etc. So after we have discovered that, then the idea is, and we know what the tumor is, then we have to decide based on what we look on the images, etc., what the patient has to undergo. Surgery, chemo, radiation, as we mentioned before, one or the other, etc. Now, there are, at some point, we have done one surgery, have done chemotherapy, or have done radiation. There are two ways. One way is, after we have done everything on the patient, the tumor recurs again. And at some point, we were on that moment that we say, well, we have done everything. What else can we do? What's next? The tumor keeps coming back no matter what we do. And you can get over a lifetime so much external beam, what we call external radiation. So that's what this gamma tile is. It brings you to especially the patient that have no more option. Of course, we're talking about the brain. We're not talking about other organs in a sense. So the brain tumor that they may have, there's no other options. So what we have, and these could be treated for primary brain tumor or secondary brain tumor, meaning metastatic tumor. So we have used these type of therapy after the patient had radiation, chemo, etc., and now the tumor comes back. We have to certainly has to be determined that the patient tumor can be removed surgically, because we need to remove at least 80-90% of the tumor to be able, or probably 100% would be the best, to be able to do this gamma tile therapy. That's why you need specialized neurosurgeon that we are here at Innova. And And then together with the radiation oncologist, we validate and we decide the placement of these tiles. Now, there are some studies that are still undergoing to see if this could be a great therapy as a first time start, meaning after we resect the tumor, we do it first. Instead of waiting for everything to fail, we start it as first. However, these clinical trials are still ongoing. So this helps in various ways. So this is one way, kind of the patient has no other option, and that's what the gamma tile may be an option. And of course, I want to make sure that everybody understands that this is not for every patient. There are certain criteria, and we have to review the images, we have to review the history, etc. So that is very important to mark here. So this is one. The second one is patients that live in the isolated areas that very far from centers, big centers that have all the radiation treatment options. And for example, they may get the surgery in one, but then they have no access to other type of treatments. And so by doing the surgery, we can right away start the radiation therapy without having the patient to come and travel for far away to get to a big center that has all the other radiation therapy options. So this is another option that has been so the patient kind of has been considered for certain patients in certain areas where they live far away. So these are kind of two of the main areas that we have been using the gamma tile, this new treatment. But as future clinical trials come out, that doesn't mean that the indication will change.
Yeah, that's interesting. You mentioned the location-based parameters and limiting factors that some people might have, just based on their geography. And that's actually one of the questions that was floating around in my head earlier when you were talking about the fact that when you do this gamma tile therapy, the radiation is sort of active for 15 days or so. And, in the interest of time, I'll spare you the extra questions, but I wondered if that would be an additional benefit as opposed to going in for some sort of radiation therapy that might be, targeted and focused in the moment, but doesn't necessarily last for that 15-day period. And again, I'm just speculating because I don't know how any of that works, but just sort of logically based on the timeline that you talked about, that is one of the things that I wondered about. Is that different from the sort of traditional radiation therapy in terms of the long-lasting effects of it or how long it's being effective?
Well, yeah, the radiation therapy, when it happens, the rate is kind of without going to the biology, et cetera. I'll try to spare everybody those details. So the radiation therapy, generally the external beam kind of type of radiation, all the proton radiation, cyberknife, and other conventional therapy or radiation therapies you radiate the tissue at that moment. And some radiation are done in one day, and some, depending on the type of the tumor and the size, etc., can be done in up to 60 days.
Okay.
So the patient has to go for 60 days back and forth from home to the center to be irradiated. So that's the difference. One of the difference. As you radiate the tissue, of course, there are a lot of mechanism or biological mechanism that happen at the molecular level that make the cancer cells die. So that's the difference. Instead, this is the radiation is placed inside the tissue and left there, and the radiation continues for 15 days. So the patient doesn't have to go anywhere; just he can be home or wherever,
right,
rehab or wherever they are. So that is the difference with these type of treatments. So when you're doing external, you have to go to the machine one day. Like some treatment are only one day, some tumors need 60 days. So you have to go every day. Instead, this is there and continues to radiate for 15 days.
I'm with you. Thanks for humoring my additional question. That's really fascinating, and I appreciate you sharing that. We are coming to the end of our conversation, but just before we finish, we've got a tradition on this show to conclude with 2 mystery questions that we ask our guests. So we have a list of 10 just to keep things fresh. So if you would, pick 2 numbers between 1 and 10, and then I'll read you those corresponding questions.
Oh, you are putting me on to test.
That's right.
Hopefully I'll be able to answer. So number 2 and number 3.
Okay, number 2 and number 3, perfect. And these are These are non-medical questions, just for the record, just so you can prepare yourself. So
Yeah.
no, nothing on the spot. Okay, number 2. If you were stranded on a deserted island, what one book, one album, and one movie would you take with you to keep yourself company? We will spot you a copy of the religious text of your choice. So other than that, what are your 3 entertainment survival kit picks?
Wow. I love reading, and I'm not very big fan of movies.
Okay. Well, then
Yeah,
maybe 2
so-
books and an album. We'll switch it up for you if you want.
Yes. So I've liked and I keep I learned a lot from as you said at the beginning I got an MBA, but I love Robert Kiyosaki's book and I learned a lot from that. There is Rich Dad Poor Dad. It's one of his books. And the other book, a very book that kind of I read recently, it's Be Your Own Banker. And that is a book that I have read it 3 times now. So it's not of course, for people that like fiction, they are not fiction books. So
Gotcha. Nice. Okay, and then how about a musical album?
Musical album, I love classical music and classical piano. I love Chopin piano,
Nice.
etudes and things. Yeah.
Do you play?
I don't. I play violin. I
cool.
haven't played it in 20 years, so I don't think I cannot say that I play.
You have played, though.
I had played.
Very
yes,
cool.
yes.
Okay, and then you said number 3. What is the best piece of advice you have ever received, and why does it stick with you?
The best piece of advice. Kind of there are so many. I'll tell you kind of the story, and I don't want to sound religious, but it is what it is. I met a few times with Mother Teresa of Calcutta, and I remember when I told her that I wanted to be a physician, and she said, "That's a great calling." She said, "You got to treat every patient like it was the body of Jesus. So that's how you have to give not only your medical knowledge, but as well your compassion and love to those patients, those families." And that kind of in my medical career, although sometimes I get lost, I try to get back to that.
That's beautiful. Thank you so much for sharing that. That's great advice for anyone, and especially a neurosurgeon like yourself. So fantastic.
Yes.
Well, those are 2 great answers, and with that, we have come to the close of another episode of the Virginia Hospital and Healthcare Association's Patients Come First podcast. If you liked what you heard, please leave us a 5-star review on Apple Podcast and subscribe so you know when new episodes are released. Once again, we want to thank our guest, Dr. Mateo Ziu of Inova, for joining us today. So, Dr. Ziu, thank you so much. It's been a real pleasure chatting with you.
Thank you very much. It was a great pleasure.